form this antechamber, it will go away.
This is a small video on the compression suture. I think I can just share from where to. It's very simple procedure, can be done in topical anesthesia. Just take one partial thickness corneal bite. It can be taken vertical, it can be taken horizontal. I prefer not to touch the two sides of the conjunctiva. So this is one you have taken. Make a cross and take one more posteriorly beyond the area of the or margin of the bleb. Okay, this is overfilling bleb that we are talking about. And then see, now you have a cross. Make 3 throws, tighten it so that you have a compression of the bleb. Once you have taken this suture, rotate the knot into the conjunctival area. If you are on the corneal side, if you start from the conjunctival side, the knot will come on the corneal side. So very, very simple procedure, but it can save a lot of complication due to overfiltering bleb. And just pull it down. And you won't believe, after a week or so, this will bury into that part of conjunctiva. You may not be able to see the compression suture. It works like that. It's just going in. So very simple. I thought I would just share how to take. So only one, how conservative you can be. Managing shallow chamber. In one case, the 65-year male had a glaucoma, and he is a one-eyed person, 636 vision. He had his surgery done elsewhere before 5 days. Trabeculectomy was done. And then he started showing rise in IOP on day 2 of the POD. And there was a history of retaking or suturing of the leaking wound by the same surgeon before 2 days when we saw him. The treatment was steroid antibiotic combination, atropine, and the injection dexamethasone. 2 cc was given every day. We don't know why, but this was the regime. And this was the picture on day 1. You can see multiple sutures, exposed knots, and the threads and irregularity with the flat bleb. So failing bleb and flat chamber. So this was the grade 1 flat chamber. Up to the pupil and posterior synechia. IOP now is soft eye because he was on multiple drugs. So what we did this Seidel test to find out why it has become so soft when the history was suggestive of very high IOP, and it was a positive Seidel. The whole wound was leaky wound, and there was a starting up of the corridals. So what to do? We enhance the treatment in form of systemic steroid, topical, we continue with the same, and then we put the BCL, which was 14.5 millimeter diameter. You can see the edge of BCL, which was covering the limbal area very nicely. And on day 3, you can see the starting of the chamber formation in this area. Now patient is responding to the BCLs, we were happy. So after 3 days, we repeated the Seidel. It was a small tiny wound here, still it was a leaky wound. We reapplied the BCL. Alternate day, we washed the BCL and reinsert for the patient. But because after 9 days, the Seidel continued, it was a time to act. We did conjunctival advancement, and though this was day 9, and with the BCL, you can see the corridals here on OCT. So we acted and we did the surgery. I will not show you the movie. And this was the picture on day 1. Stable chamber. Everything was fine. Well-formed chamber. Continue with the steroid for a fast tapering dose. And on 8th day, it was a quiet eye. Everything fine, 612 vision, patient happy, we were happy, IOP 12. So every time you do not have to do something surgical. Simple conservative management can work in your case. So thank you very much for the patient.
Thank you, Mayuri.